Hello, and welcome to our program, A Wake Up Call, Improving Recognition and Management of Excessive Daytime Sleepiness in Patients with Obstructive Sleep Apnea. Today, we will focus on the pathophysiology and treatment of EDS and OSA. If you've not already done so, please complete the program pretest at www.integrityce.com/EDS pretest 2. I'm Dr. Seema Khosla. I am the medical director of the North Dakota Center for Sleep in Fargo. I have a background of pulmonary, critical care, and sleep. I'm joined today by my colleagues, Dr. Michael Thorpy and Dr. Andrea Matsumura. Dr. Michael Thorpy is a professor of neurology at Albert Einstein College of Medicine. He's also the director of the Sleep-Wake Disorder Center, Department of Neurology, at Montefiore Medical Center in Bronx, New York. Dr. Andrea Matsumura is a sleep medicine physician at the Oregon Clinic, Department of Pulmonary, Critical Care, and Sleep in Portland, Oregon. Our faculty disclosures are displayed on the screen for you. Over the course of today's discussion, we'll be addressing the following learning objectives. We will summarize available treatments for EDS in OSA, including the impact on daily function and quality of life. We will also integrate patient education strategies when prescribing wake-promoting agents to optimize patient outcomes and adherence. Before I pass this off to this excellent panel, I want to introduce you to our case patient, Matthew. Matthew is a 55-year-old man. He is an assembly line worker at an automotive plant. He is obese with a BMI of 33 kilograms per meter squared and has a diagnosis of hypertension that is controlled with medication. He also has type 2 diabetes, and his last hemoglobin A1C was 7%. He has a 5-year history of obstructive sleep apnea that's been treated with CPAP and has been diagnosed with EDS despite optimal CPAP for OSA. So given the diagnosis of residual EDS, what therapeutic options are available to Matthew? Andrea, I'll toss this one to you.
So basically, there's a fair amount of different therapeutic options that are on the market in terms of pharmacological therapy. And that's what we're going to be discussing in detail today.
Dr. Thorpy, what factors would you take into consideration in selecting a treatment?
Well, you have to look at the whole patient, and that's very important. So you need to look at their other medical conditions. You need to look at the severity, obviously, of the daytime sleepiness. You need to look at their sleep patterns. And so it's a number of factors that are important in deciding what would be the appropriate medication for a particular patient.
So speaking about his comorbidities, Andrea, how do those comorbidities impact your management approach?
Well, definitely you want to, before you think about starting on medications, you definitely want to ensure that the person is maximizing their sleep opportunity, making sure that there aren't any other external factors that are inhibiting their ability to sleep. Sometimes people can't get enough sleep because they have to work more than one job. Other times, people are pushing their bedtimes later than they should be. And so a lot of it is making sure are their general habits conducive to allowing them to get enough sleep. But then at the same time, are there other medical conditions that may be preventing them from being able to obtain that potential sleep opportunity that we all should be having?
Oh, what great points. With all of that, I'm going to pass it over to Dr. Thorpy to discuss considerations for treatment selection.
Good. Thank you, Seema. Okay, next slide. Okay, so we're entering the age where everyone's talking about personalized medicine, and this is certainly very important for the patient with obstructive sleep apnea syndrome, because not all patients are the same. Patients vary a lot in terms of their sleep habits as well as their comorbidities. So when we need to decide about management for excessive sleepiness in a patient, we need to really consider a number of factors. Now, that's shown on the slide here. You can see that there are psychiatric and medical factors. One of the more important areas medically, of course, are cardiovascular disorders in these patients, which are relatively common. Patients with sleep apnea can have atrial fibrillation, cor pulmonale, and a whole lot of other arrhythmias and cardiac events. So we need to take that into consideration. There are also the psychiatric disorders, particularly anxiety disorders, which may interfere with the treatment that we would give for excessive daytime sleepiness. And there are other medical conditions that you would need to evaluate as well. And not only just those factors, but also pregnancy can play a part. We know that sleep apnea is more common in pregnant women. So that certainly is going to influence the treatment of any daytime sleepiness. Then there's the occupation of the patient. I mean, are they a shift worker, for example? Are they doing some dangerous activities and have excessive sleepiness? And so you really need to take that into consideration. And then you need to look at the patient goals. I mean, what's important for the particular patient? Because we can't do treatment in isolation. We really need to do it in conjunction with the patients and their wishes. Next slide, please. So when we come to treatment, we think about pharmacological treatment and we think about non-pharmacological treatments. So if they have comorbidities, obviously it's most important to get those under control. For example, diabetes, if a patient's blood sugar is high, it's going to make their sleepiness worse. So you want to get their diabetes under good control. Any cardiovascular problem needs to be controlled, including blood pressure, for example. So in Matthew's case, he had both diabetes and hypertension. And so we need to make sure that those factors are under control. Then we need to look at the sleep pattern. We want to make sure that the patient's getting an adequate amount of sleep at night. If they're cutting themselves short of sleep, then that's going to be a big problem. And if they're a shift worker, then they will have a disrupted sleep-wake pattern that's going to impact on their daytime sleepiness. So they'll have both the sleepiness related to their shift work plus the sleep apnea. And we need to think about judicious use of naps. In general, when it comes to napping, if a patient has to take a nap, we prefer that they take it, but keep it short because we don't want that nap to take away from their nighttime sleep. We really want to maximize their major sleep episode. And of course, we need to look at what medications a patient's taking. Are there medications that will cause them to be more tired and fatigued and sleepy and make their sleepiness worse during the daytime? Or are they on medications that are more disruptive to sleep, making their sleep worse so that they're going to be more sleepy during the daytime? So most important that you consider a number of factors here. And then there's the psychosocial support. Now, we know with patients with sleep apnea, it's very often the spouse that's concerned because of the snoring, and it's often the spouse that's been more aware of the patient's daytime sleepiness. And so, we need the support of family members and the encouragement of family members for the patient to maintain their treatment and to be aware when the patient's treatment is not being that effective so that the clinician can be advised about that and to make alternative choices for medications. Next slide. So what are the medications then that we use for excessive daytime sleepiness in a patient with sleep apnea? Well, there are 3 FDA-approved medications, and they're listed on the slide here: Modafinil, Modafinil, and just recently in 2019, we had the approval of this new medication called solriamfetol. Now, these are all dopamine reuptake inhibitors, and solriamfetol has the additional advantage of being a norepinephrine reuptake inhibitor. Dopamine and norepinephrine are 2 neurotransmitters that tend to be somewhat alerting. And so by being a reuptake inhibitor, then it's going to tend to increase their alerting aspects. They're all very effective for excessive daytime sleepiness. And if you use the Epworth Sleepiness Scale, we find in the studies that have been done, and Andrea is going to be discussing the studies in a few minutes, and you'll see that the sleepiness measures tend to be improved with these medications, and there's significant improvement. So these are all effective medications for treating sleepiness in the sleep apnea patient, but they come at a cost, and you can see the adverse effect profile here. Most commonly, headache is very common. These are alerting medications. Most alerting medications tend to be somewhat stimulatory so that they can produce headache. And then also you'll see then this nervousness, anxiety coming through, so that those symptoms can be worsened by these medications, which may be a problem if the patient already suffers from anxiety. So there are a number of factors there with the adverse effect profile that we need to consider.
So I'm going to be talking about the treatments for excessive daytime sleepiness in patients who, so for instance, this patient that we discussed who may have excessive daytime sleepiness with obstructive sleep apnea. And so what this first slide shows is modafinil as an adjunct therapy for daytime sleepiness in a patient who is already being treated for their sleep apnea. And what this really shows, if you take a look at the different axes, the mean for sleepiness score, and that difference when we provide people who are already optimally treated on their continuous positive airway pressure, or CPAP, and we add that modafinil, it really does reduce that mean sleepiness score. So however subjective that score is, it is really kind of a window into that patient's perception of how sleepy they may be. And what we see here in this is that at baseline, 1 week and 4 weeks, we do see a change in that subjective feeling and those perception and symptom of sleepiness. Next slide. So then this is a different type of scoring of functional outcomes of sleep questionnaire, or FOSQ. And again, what this slide is showing is that at baseline, 1 week and 4 week, in that slide or the graph on the left-hand side of you is showing that indeed the functionality of a person's ability to perform various tasks. This is a 10-point questionnaire that has a various scoring system. And what it really shows you is that with the addition of pharmacological therapy with a patient who is already optimally treated with CPAP, that there is a change in the function that's statistically significant. And then when you see here with their activity level and vigilance, which is on the right side of the graphs, you again will see there is an increase in their activity level and the vigilance that a patient may have from baseline to week 4. You do see that there is this change in their functionality overall. And next slide. This is just another way to be able to show how these medications, so modafinil, armodafinil treatment for residual excessive sleepiness associated with sleep apnea. This again shows that mean sleep latency over time in that left-hand side of the graph, showing at 4, 8, and 12 weeks that initially you'll get some change and then it starts to kind of level off with this medication, even at 250 milligrams a day dosing versus the 150 milligrams a day dosing. And what you'll see is at the bottom where it says sleep latency is assessed using the maintenance of wakefulness testing. And on that left-hand side of the screen with that chart at 9, 11, 1 and at 3, then you'll start to see that there may be some leveling off of that feeling of wakefulness. And then on the right side, moving forward in 4 weeks, 8 weeks, and 12 weeks, that they begin to have that same leveling off with that mean sleep, with the mean sleep latency testing. But by and large, they do help, but there is some plateauing in their efficacy. Next slide. So then this is the impact of Sunosi or solriamfetol on wakefulness and sleepiness in patients. Again, patients who are optimally treated for their sleep apnea using positive airway pressure, CPAP, and then the addition or pharmacological therapy because of that excessive daytime sleepiness. And what you see again here, ideally with the maintenance of wakefulness test, is that you want to see longer latency in a person's sleepiness. So we want them to stay awake during these studies, right? And what you see here, again, from baseline to 12 weeks out, is that they do indeed have more wakefulness with the addition of these medications, and it tends to be a dose respondent type, a dose response. So the higher the dose, typically, you'll see then the longer latency to sleepiness and a maintenance of wakefulness test. And again, in the graph B, what you see is that change in baseline, again illustrating that there is a significant change in their residual sleepiness with the addition of pharmacological therapy. Next slide. And then overall, this data here, this last slide, is on the long-term safety and efficacy of Sunosi for excessive daytime sleepiness in narcolepsy or in sleep apnea. So this report, this is reporting rather the patients and then also clinician reporting in terms of that the impression of change. And this is quite significant here, showing that with the use of a medication like Sunosi, there is some improvement in the impression, the change, how they clinically feel. So that again is showing that there is a need and an indication and use for medications like this when we appropriately assess a patient and all of those factors that Michael talked about, and then deciding, do we need to add a medication on top of optimal therapy of CPAP? And then certainly for patients who have narcolepsy, those patients have some significant improvement in lifestyle and in functionality when we're able to provide them with pharmacological therapy so that they are not impaired in their daytime life.
Matsumura. So let's return to our case patient. Dr. Thorpy, I'll throw this question out to you. What type of pharmacotherapy, if any, would you recommend for Matthew?
Well, we have the choice of those 3 medications: modafinil, armodafinil, or solriamfetol. In general, most patients do better with the armodafinil because it does have that longer duration of effect. And as Andrea showed, that these patients can be helped not only in the late afternoon, but even the early evening. But you don't want them to adversely affect sleep at night. So and then there's solriamfetol. So solriamfetol also has a good duration of effect throughout the day, and it's a relatively new drug, and it's a very effective drug. So we could consider either the armodafinil or the solriamfetol. He has high blood pressure, so we need to consider that aspect, and we don't want medications to adversely affect it. Solriamfetol certainly can increase blood pressure slightly and heart rate, but any of the alerting medications have that tendency. So we really have to be careful with any medication that we give a patient who has hypertension, that there's a possibility that an alerting medication could exacerbate that. But I think in Matthew's case, if we can get approval, which of course is always a problem with new medications. Solriamfetol is a relatively new medication, so the older medications tend to be more easily approved by the insurance carriers. But ideally, he would be treated with the solriamfetol, unless he was not able to get it through his payer, in which case then you would go to the Modafinil.
You've raised some really excellent points. Dr. Matsumura, in addition to initiating that appropriate therapy, then, what other strategies would you employ to help Matthew achieve optimal control of his condition?
Well, there's a number of other things to consider, and I think we touched on that really at the beginning of this conversation. So just making sure if there's other chronic medical conditions that might be potentially affecting his sleep, ensuring that he's optimally treating his sleep apnea. So I would make sure to check on that routinely. Sometimes patients initially will feel like they're getting great efficacy, great treatment with the CPAP, and then it kind of dwindles off. And sometimes there's a lot of other external factors that may be causing that. So I think making sure that you're treating the whole patient, as we had discussed at the beginning of this whole conversation, and making sure that we're asking the patients about all of those factors that could be affecting somebody's wakefulness and their ability to get refreshing sleep.
Those are all really important points to consider. Dr. Thorpy, yep. Can you discuss improving long-term outcomes for patients with OSA-related EDS, please?
Right. So if we go to the next slide. Oh, sorry. Go back a slide. Okay. So this slide really summarizes what we've been discussing. I mean, there are patient preferences with regards to the treatment, so that there is not one medication that suits all patients. And this is one of the things we find with the alerting medications, is that there's a lot of individual patient preference when it comes to these medications. And so although we may think a particular drug is ideal for a patient, the patient may find that it just doesn't agree with them. So we have to take that into consideration. We've talked about the adverse effect profile, the anxiety, potential for stimulating cardiac aspects and increasing blood pressure, palpitations. Even migraine can be worsened by these medications. There's the cost factor involved, the efficacy of the medications. Fortunately, these three drugs are pretty efficacious. There is a slight difference in terms of their duration of effect, with the Modafinil working a little bit longer during the day than the Modafinil, but not a lot of differences in terms of efficacy for these medications. And then, of course, we've got to consider drug-drug interactions and any drug that may interfere with these medications, which may or may not be metabolized in the liver. Next slide. So we have these three medications, and as I mentioned, solriamfetol is a newer one, but in terms of the being efficacious, they're all very efficacious. Next slide. Next slide. So if we come back to Matthew then, Matthew was initiated on one of these treatments, and he was reporting improvement in his symptoms of sleepiness. Doesn't have the urge to nap anymore during the daytime. He's able to stay alert when driving. He's noticing general improvements in his mood and functioning at work. So overall seems to be doing well. Next slide. But we need to consider what's happening after the initiation of treatment. And this is where the physician and the patient both have a role in this. So the physician needs to be continuously monitoring the patient, looking for the development of any adverse effects. Also, you don't want, when you give a patient an alerting medication for their sleepiness, you don't want them to start reducing their use of their CPAP. So you need to monitor their adherence to the CPAP and make sure that they're using their CPAP for a good amount of time at night, which should be at least 8 hours at night. And you want to confirm the effectiveness of their CPAP by getting a compliance data, looking to see if they have any residual apnea, whether they have mask leak, etc. So that needs to be an ongoing process with the patient. And it's going to vary from patient to patient. Some patients do fantastic on their CPAP, and even though they're on a medication for their sleepiness, they just consistently use their CPAP in an appropriate way. And so you may not need to see them very frequently, but other patients may have a lot of difficulties, and you may need to be in frequent contact with them every few weeks to monitor that adherence, make sure they're using the CPAP effectively. And then there's the medication. I mean, typically we would start at a lower dose and see how the patient tolerates the medication, but then we may need to increase it at some point. And we may need to change it if we find that the particular medication, it doesn't seem to be very effective for that patient. Then we would want to change from one to another medication. The patient has an important part to play in this whole process too. I mean, they need to really pay attention to their sleep pattern. They need to make sure that they are getting that good amount of sleep, that they are using their CPAP appropriately. So they need to maintain good sleep hygiene, avoiding alcohol before sleep, relaxing time before bed at night. And if they have napping during the day, it should be kept pretty short so it's not taking away from that nighttime sleep. Then they need to do exercise and good nutrition and try to get their weight down. Most of these patients, of course, are overweight. So if we can get their weight down, that's going to help them overall. Not only help their apnea, but it's going to help reduce their sleepiness a little too. So we want to encourage them to do that. And then we need to assess what is the patient's lifestyle. What are they doing? Are they people that are in dangerous sort of occupations? Are they shift workers, as I mentioned earlier? Do they do a lot of driving? Maybe they're a commercial driver. So all these things need to be taken into consideration and discussed with the patient. And then if a patient is a family man and has young children, particularly, you need to be careful about the medication and where it's stored, because you don't want children accidentally getting hold of any of these alerting medications. So, looking after and storing the medication in a safe place is important for anyone who has sleep apnea, male or female. Next slide.
Thank you.
Back to you, Seema.
I'm going to add just to that. That was a really excellent summary on how, incorporating everything that is potentially affecting that patient's life. But one of the key takeaways for me is setting realistic expectations. So oftentimes when I have patients have excessive daytime sleepiness, and we do go down this path of pharmacological therapy in addition to their CPAP, I often will set the stage for letting them know that this is about reducing impairment, but it's not necessarily going to make them feel like they're 20 again. and that in reality, this is about functionality and being able to stay awake if you have a commercial driver's license. Stay awake if you're having to perform specific duties at work, or feeling like you're afraid that you're going to fall asleep. But in reality, I think the best thing to do is that we can all do is set those realistic expectations for patients.
Very good. I'd just like to add that, many patients that are treated with CPAP, after they get the CPAP, notice a dramatic improvement in their symptoms. And they may think that that's all there is to their management. But you need to assess sleepiness in a particular patient, even though they're having a good response to their CPAP, because the patients often don't talk about it. And you may find if they're driving, they could be at risk. So sleepiness and a residual sleepiness in a sleep apnea patient in general is very undertreated. And it's because the patient notices initial improvement and thinks that's all that there's going to be. But it's up to the clinician to really bring out whether that patient does have significant sleepiness in addition to using their CPAP effectively, because we do have these better treatments available and we can make a difference to these patients.
Yeah, it's that old phrase, you don't know what you don't know kind of thing, right?
Exactly.
Very true. Well, thank you both for a very informative presentation. The pieces that really resonated with me, Andrea, you talked about setting expectations. And Dr. Thorpy, you pointed out how you do need to appropriately time the medication if you have maybe a shift worker or something like that. And it really brings it down to how we need to personalize our treatment for our patient and weigh out the risks and benefits while also considering their other medical problems and medications. We've covered a lot of content tonight and had a lot of great discussion. So let me just summarize everything we went over. There are currently 3 approved therapeutic options for OSA-associated EDS, all of which improve objective measures of sleepiness and patient-reported outcomes, and they all demonstrate good safety. EDS and OSA are strongly associated with the presence of comorbidities, particularly cardiovascular disorders, which are key considerations over the course of disease management. To achieve optimal outcomes for patients with OSA-associated EDS, treatment must be highly individualized based on the presence of comorbidities, as well as patient preferences, goals, and lifestyle. So it looks like we're out of time for tonight. To this excellent panel of faculty, thank you for your time and for sharing your knowledge and insight with us. It was our pleasure to have you. For our audience, thank you so much for joining us today. Please make sure you claim your CME credits by completing the post-test and the evaluation form at www.integrityce.com/EDS-eval2 and look out for more programs to earn CME credit. Thank you, everybody.
Thank you.
Thank you.